Okay, hi everyone, I'm Anna Peake. I'm a children's orthopaedic surgeon.
Hi there, my name's Dr. Damian Roland. I'm a paediatric emergency medicine consultant who works here in the children's ED.
And together we're going to talk to you today about paediatric trauma and how we would like you all to manage it within the ED context. We are going to attempt to answer these three critical questions. Who needs an intervention right now in ED? Which children need to be admitted? And which children need to have a surgical operation? I'm going to hand over to Damian for this.
Okay, so there's a couple of pretty well-known characteristics of children who need something doing almost immediately. The concept of the 5 Ps, especially those kind of children who have literally lost a pulse, everything's gone pale, and you know that there's no circulation to the end of the limb. There is also some children who are in so much distress need some form of intervention as well as pain relief to relieve some of that discomfort. And you will know about that pretty quickly because, by and large, our staff are pretty well trained at highlighting almost immediately as they walk through the door that something needs to be done now. So that these are the type of patients where you get a phone call in a hurry rather than a bleep to come and help us out. There are sometimes situations where you may feel something needs to be done urgently, and maybe you feel that the team around in the ED don't share that sense of urgency. I think it's always worth just being honest. Please don't just put your head down. Have a chat with the doctor in charge to explain your particular concern, because it may well be that the ED staff don't realise that something is quite time critical about this, or it may be that we're experienced enough to know that there's a different way of doing something about it.
So who needs intervention now? So basically children who have an immediate neurovascular deficit from their injury, that fracture or that dislocation needs to be reduced to restore the blood supply to the nerve and the distal limb. And as you all know, we generally feel rather uncomfortable with the idea of dislocated joints being left out, although that doesn't, in the absence of neurovascular deficit, that doesn't always carry quite the same urgency. So hopefully we've answered that question. And the next pertinent question is who needs admission? So there are children who need to go to theatre urgently. So the classic example is a supracondylar fracture with a pulseless hand or a white hand. I think that children who have slipped upper femoral epiphysis all need admission. There's some debate as to whether stable SUFIs should be admitted or not, but I think the majority of people would take the view that the safest option is to admit all children with a slipped upper femoral epiphysis. Clearly, children who are systemically unwell need to come in. I don't think anyone would argue with that. And obviously, if you've got a concern about NAI, then the child needs to be admitted. Anything you want to add to that?
I think the only thing to add is that not knowing what to do shouldn't be grounds for admission. And I think from our point of view, we've got a wealth of experience within the ED of what normally happens to these types of patients. And so please don't admit someone just because you're not sure what the orthopaedic consultant or someone else, because you're unsure what they would like to happen. Just ask us or phone them. Uncertainty isn't grounds for admission.
The only other thing I would add is that there are a group of children who are at particularly high risk of developing compartment syndrome in the hours after their injury. And if you have got concerns that the child might develop compartment syndrome, then I think you need to think quite hard before sending them home. And it depends a little bit on the family circumstances and how readily you think the parents will bring the child back if they are in a lot of pain or exhibiting symptoms of compartment syndrome. But that is a consideration after significant injuries. And again, supracondylar is a very is probably the injury most associated with compartment syndrome, and it will then obviously depend on the situation. The next question we need to answer is who needs surgery, and that's a really a difficult question with an ever-changing answer, because we sort of often think we know the answer, and then there's a change in practice, and then we suddenly feel that we don't know the answer anymore. And the first thing to say is that a lot of these decisions can be made at the next morning, and that the child, if they do need surgery, can always be recalled for surgery. So there's not very many children who need surgery right now. Most children, if they do need surgery, can come back for it. We're going to talk about some fractures which probably traditionally we would have all felt definitely needed an operation, and this is a radius and ulnar fracture which is completely off-ended, and I'm sure the child's arm looked very bent, and we can all agree on that. And the traditional answer to this would definitely be that the child needs at the very minimum an MUA under GA and probably some K-wires as well. But actually, I would put it to you that a cast which restores the axial alignment, even though it's not anatomically reduced, can result in a very good outcome, and that's because we've got this wonderful thing called remodelling. So here we are, here's the child united. I think he's about 6 weeks down the line, maybe a little bit more, maybe 8 weeks, full range of movement, a little bit of a bump. He will remodel to a fully functional forearm, and that's happened without any other intervention other than a manipulation under ketamine to restore the alignment of the bones. This is a very bent forearm. Again, both bones, quite unstable injury, very bent. Child has again a manipulation under ketamine, rather nice reduction, and is united very nicely, full range of movement and no surgical intervention. So neither of these two children needed admission. I'll pass you over to Damian.
Excellent. So one of the things that we have learned a lot about in the time of COVID is expanding our use of sedatives, both ketamine, but also judicious use of kind of Entonox and other intranasal agents. One of the things that can frustrate people is the words that it just needs a tweak. We worry about that in children because we have had prior experience of that tweak turning into a more painful procedure which the child doesn't tolerate. Given the changes in COVID, we are very open and receptive to trying to do procedures with judicious amounts of analgesic and especially now ketamine to try and get stuff back into decent alignment. There are things that can be done pretty easily. Those things at the bottom where you've not only off-ended, but it's clearly going to be very difficult to return to any form of normal kind of position are going to need a different approach. But our ask is really, if you'd like to do something in the department, come and speak to one of the senior doctors there, explain what you need to do, and we will work hard to make sure that we can provide the sedation that you need for that procedure. Just be aware, at night, especially after 11 o'clock, we sometimes struggle with staffing levels, and it's not a given that we'll always be able to do the sedative procedure that you'd like, but that is something we're working on.
I'll just talk about these X-rays at the bottom. Why can we not do the two at the bottom? And I said the one on the left with the both bone forearm fracture, you can see that that's a really unstable, very proximal fracture configuration, and that even with the best wind in the world and the best cast in the world, it's really going to be very difficult to control that fracture through plaster alone, and therefore that's a situation where actually the child does need to have an operation. And if the child needs to have an operation, then they don't necessarily need to have sedation under ketamine, because that's just subjecting them to two procedures that they don't need. So that's the first one. The second one, you can see the distal radial ulnar joint is completely dislocated, and again realistically, that child does need to go to theatre and have a more definitive fixation, and therefore please don't try and sedate these children with ketamine. Because it's subjecting them to an unnecessary procedure, unless there's a neurovascular impairment, in which case then they do need to have their arms straightened so that the nerves can get some blood supply back. I'm going to talk about what we're aiming for in the manipulation, and I'm going to try and use an example where things didn't go perfectly to try and explain where we can go wrong. So we're trying to restore, and I'm talking primarily here about forearm fractures and also to a lesser degree about tibial fractures. The primary aim is to restore the axial alignment rather than to obtain anatomical reduction. And ideally, if you're giving the child ketamine in particular, you want to put your definitive cast. So you don't want to just put a back slab that is immediately going to lose its position. And you obviously then need to give advice with regards to compartment syndrome and so on and so forth. But you can use definitive casting as long as you give the correct advice and warning warning advice to the parents. So this was an 8-year-old girl. She has a fracture very similar to the one you saw a few slides ago. Both quite distal, both bones are gone. And it's completely off-ended, as we can all see. And you can see that here the axial alignment's not restored. And so she was given ketamine. And there was an attempt at reducing the fracture anatomically. And I think that's where things went wrong, because in trying to restore the anatomy, the axial alignment kind of got blown away to the side a bit. So not only were we unable to restore the anatomy of the radius, but also we haven't reduced the axial alignment. You can still see that essentially the wrist is really not pointing in the right direction. There's nothing inherent in taking a child to theatre means that you must put a KWAR. The chances of the child getting a KWAR in reality are clearly is significantly increased if they end up having their MUA in theatre. Because, if the metal's there, we're all just going to reach for it, aren't we?
But just about why not fracture clinic? So sometimes get asked, well, can I just take this patient to fracture clinic to get some of these stuff done? I think that the key thing is that there's a lot of safe equipment and sedation availability that just doesn't exist in fracture clinic that we have access to in the emergency department. And it's not that we're overprotective about it, and it's not that fracture clinic don't always want these patients, but that the best place for some of these manipulations and some of these procedures is within the emergency department, because not only do we have access to the staff, we have access to oxygen, and we have access to the techniques and the procedures and the protocols to make sure that these kids don't come to harm.
So why can't it be done in theatre? Well, it can be done in theatre is the short answer. But one of the points I've tried to illustrate is to do with how much more aggressive that is as an intervention. And I think it's important just to remember what the journey is for a child, especially in COVID, who has to come into theatre. So they break their arm. They come into the hospital and they're in ED. And there's two options here. They can either have a sedation and go home that's the very same day or evening, or possibly even come back for sedation at a later date, but still go home in a fairly rapid space of time. Or they get admitted. They need to be clerked in. There's quite a big nursing staff input as they get admitted onto the ward. They may then block the bed of an elective patient who was due to come into that same bed and who might have been waiting for their operation for 9 months or more. Then they wait. At the moment, children are going on the emergency list, so they might easily wait all day. At other times, the children go onto the trauma list, which, let's face it, is not any less busy. So realistically, these children are then waiting a long period of time. They have a full general anaesthetic. There's no sedation given in theatre. So, that means they have an airway procedure. It's an aerosol generating procedure at the moment. They go down to theatre. They're greeted by the anaesthetist, who's in the full gas mask, Darth Vader thing. It's a terrifying experience, and it's a much more interventional experience than having the problem sorted out straight away in ED. And then the final point, which maybe it's a minor point, maybe it isn't, is vastly more expensive for the hospital to admit a child and bring them into the operating theatre compared to dealing with the problem in ED. Our resources are not infinite, unfortunately, and if we can save our resources for the children who definitely have to go to theatre, then that's just better for everybody.
Excellent. And I think to finish off with, we've given you some quite loaded information here. We don't want you to take people to theatre, but we want you to take some children to theatre. It's not always easy. So there are some what ifs. So there are situations where we can't provide the sedation that either might be needed, and there are often a variety of reasons for that. One of our things is please speak early to the doctor in charge. Between the hours of 8 in the morning and generally 1 in the morning, there is a children's emergency department consultant who you can discuss with things. For a variety of reasons, we can't always provide the sedation that you'd like. We are definitely improved on that compared to a couple of years ago, and during the day we can do most things. Things do become a bit trickier in the evening, so please don't promise to parents that something's going to happen at midnight because it doesn't always happen, but that can always be a discussion that we have ongoing. Sometimes there is some subjectivity, so that the plan from your end or from our end there isn't a general agreement on. Again, I think some of these problems occur because of kind of discussions between junior members of staff, and I always feel much more comfortable when I've had a direct conversation with the registrar rather than, with all due respect to your orthopaedic SHOs, sometimes they put a plan in place which some of our staff react to, and then you have to pull everyone back. So it's always best just to have a conversation with the most senior person there. The PEM consultants, we are not orthopaedic experts, but we have done a bit of orthopaedics, and we have a wealth of experience in terms of normal outcomes of these patients. So if you've got a concern, you're not sure what would normally happen or what normally happens at this hospital, just ask us, because if we don't know, we'll get the answer for you. And also, as I'm sure Anna will explain, that the orthopaedic consultants are very happy to take a call.
Yep. So please don't admit children because you don't know what to do. There's lots of people around. If you're an SHO, please ask the registrar. If you're a registrar and you're really unsure whether the child needs admitting, then please call the boss. If you're not sure, please give us a call. And also, or if you're in ED and you're unsure whether the child needs to be admitted, you guys have senior support as well. Please ask your registrar or your consultant or the orthopaedic registrar. One of the what ifs, you can't agree on a plan. Guys, you just need to talk to each other and agree on a sensible plan that's in the best interest of the child, and that's what we want you to focus on. And there are going to be occasions when ED cannot safely provide sedation, and so the sedation needs to be done safely, and we can't put the life of the child at risk in order to straighten their arm. So if ED can't provide sedation at the time when you would like to do it, then often there can be a plan to bring the child back at a time when the department is not heaving and when the appropriate people are around, and then sedation can be provided. So it may be that you need to bring the child back the next morning, and that should be discussed with the ED team, and it then needs to be handed over to the morning team, because probably you won't be the one doing the manipulation. And the child then doesn't need admission, they just need to be brought back to ED in daylight hours. And that has been what's happening during the COVID crisis. It's been happening very successfully, and we do hope to be able to formalise that arrangement a bit further for later in the winter when things get better. But at the moment, it's done on an informal basis, and you do need to speak to the senior person in charge of ED to make that plan and agree that that's an appropriate plan. I think that's it.
Brilliant.
Thank you very much for listening to us.